Hello and welcome, everyone. Thank you for joining us for the Lichen Sclerosus Support Network event for LS Awareness Day tonight. We are so excited to be joined tonight by Dr. Jill Krapf. Jill Krapf is a board-certified OB-GYN specializing in female sexual pain disorders, and she is director of the new Jill Krapf MD Center for Vulvovaginal Disorders in Tampa, Florida. She is a fellow of the International Society for the Study of Women's Sexual Health, also known as ISWISH, as well as the International Society for the Study of Vulvovaginal Disorders. She's also a Menopause Society certified practitioner. Dr. Krapf is active in research and has published chapters and peer-reviewed articles on vulvodynia and vulvar lichen sclerosus. She is associate editor for the medical journal Sexual Medicine, as well as for the textbook Female Sexual Pain Disorders, the second edition. She's also an author of the trade book titled When Sex Hurts, Understand and Healing Pelvic Pain. Dr. Krapf shares educational content and details on her new practice located in Tampa, Florida, as well as on Instagram, which is at Jill Krapf MD. Tonight, her presentation is titled Scratching the Surface, Unraveling Sexual Health with Lichen Sclerosus. I just wanted to real quickly re-emphasize the message that came across at the beginning of this presentation, that she is not allowed to give any individual medical advice, though you are allowed to ask general questions and post comments in the chat. And I just want to thank you all so much for your time spending with us this evening. And if you have already donated to the mission of LSSN, thank you so much. And please continue to support our work and attend our events. We hope this is helpful for you all. I'm now going to hand it over to Dr. Krapf.
Hello, everybody. So I'm so honored to be here tonight with all of you celebrating and bringing awareness to World Lichen Sclerosus Day. Today, I saw patients in the office with lichen sclerosus, and I do every day that I'm in the office. And so I'm excited to speak with you tonight about some common concerns and questions that people have concerning lichen sclerosus. And I also want to leave a lot of room to answer your questions. And so with that, let's go ahead and get started with the presentation. All right, we can move to the next slide. So just some disclosures and disclaimers. I do serve on the advisory board for Lichen Sclerosus Support Network. It is a volunteer position. I am not paid for that. I'm not paid for tonight's talk either. This is an educational session. It should never be considered individual medical advice. So if you need individual medical advice, please see a healthcare practitioner familiar with your condition, or if you would like to see me, I would be happy to take care of you, but I can't answer any individual medical questions tonight, only general. So if you're going to frame your question, make sure it's in a general sense. Any patient cases that I discuss are hypothetical and based on a combination of patients and their patient presentations, not on an individual patient. So if anything sounds familiar, it's by design. All right, next slide. Okay, so our learning objectives for this session tonight is we're going to identify the sexual health consequences of vulvar lichen sclerosus in people of all ages. And I think it's really important to emphasize that lichen sclerosus happens in people of all ages. We used to think that this was just a condition of postmenopausal women, and we knew that it happened before puberty. But we now know that this happens in people of all ages in their 20s, 30s, 40s, 50s, 60s, 70s, all the way up. So really important to recognize that. I would like to empower you to be able to discuss sexual health with your healthcare providers, as well as with anybody in your life that you feel that you would like to share this with. I also would like you to be able to implement a vulvar healthcare plan that really promotes sexual health as a big part of it, because sexual health is health. Next slide, please. So let's start with what is lichen sclerosus. Well, if you're here in this webinar, then you probably already know what lichen sclerosus is, but just in case, it's an inflammatory skin condition. It predominantly affects the anogenital area. It can occur on other parts of the body. It's just less likely to do that. It's autoimmune in origin and it has a genetic component. So, up until I would say about maybe 5 or 6 years ago, I couldn't even say that statement because we really didn't know what caused lichen sclerosus. And there was some theories about it having a genetic component, but we really, in the past few years, have acquired a lot of evidence and research to show that it is actually a local autoimmune condition. And we have identified the genes that are upregulated and downregulated in this condition. There's still a lot to learn with the mechanism of lichen sclerosus, but at least we can kind of go in the right direction with labeling it in that way. It affects people of all ages, but it's most often diagnosed around or after menopause. And there's a few theories of why that is. Some people think that it might have to do with estrogen levels. And we know that when estrogen levels are low for whatever reason, whether that be menopause or perimenopause, or after childbirth with breastfeeding or certain medications, we know that people that have lower estrogen tend to have more itching. And so we think that it might be a detection bias in that if someone has more itching, then they're more likely to be recognized to have lichen sclerosus or receive a biopsy and get a diagnosis. Inflammation in the skin leads to skin thickening and scarring. And we're going to spend a lot of time talking about those two separate components. Lichen in Latin means thickening, and sclerosis in Latin means scarring. And so I want to try to divide these symptoms a little bit because even though they have the same origin as far as how they occur with inflammation, they can be treated a little bit differently. It is not curable. Lichen sclerosus is not curable, unfortunately. However, it is manageable. And so just like a thyroid disorder, how people have to potentially take Synthroid or another thyroid replacement or what have you, it's similar in that way. We do recommend maintenance therapy, although sometimes it can go into remission on its own, and I can certainly answer any questions regarding that. Next slide. All right, what are the symptoms of lichen sclerosus? So along the theme of what we were talking about before with separating this a little bit, we're going to talk about the lichen or thickening symptoms, and then we're going to talk about the sclerosis or scarring symptoms. So typically, when there is thickening of the middle layer of the skin, which is what happens in lichen sclerosus, this leads to itch. I included just how we talk about this in normal life. And then in parentheses, I put the doctor terms in there because I think it's helpful when your doctor talks about it, if they're not translating it, or if you look at your medical note or you're reading about it in a journal or a textbook, it's really helpful to put these things together. So itching, which we call pruritus, irritation, there's not a special term for that. White patches, we call that hypopigmentation, which means hypo means low and pigmentation means pigment, right? So low pigment or whitening. And lichenification, which is a mouthful, it just means thickening. So white patches are the whitening and the thickening together. We can also see paper cuts or cracks. We call that fissuring or fissures. And then sometimes we can see some blood get trapped under the surface of the thickened skin, and that results in a bruising appearance, and we call that purpura. The scarring symptoms of lichen sclerosus include coverage of the clitoris. We call that clitoral phimosis. And then the stickiness of the clitoral hood to the clitoris, we call that clitoral adhesions. Adhesions are essentially tissue that's stuck together. Narrowing of the vaginal opening is introital stenosis. The introitus is the vaginal opening, and then stenosis just means narrowing. And then pain with intercourse, we call that dyspareunia. And then tearing, that's a mouthful, but we call that vulvar granuloma fissuratum. And you'll hear that fissure in there because it refers to the tearing. Next slide. How common is lichen sclerosus? So that's a really good question. The bottom line is we really don't 100% know. The estimates in research are anywhere between 1 in 300 to 1 in 1,000 people in the general population. We know that there have been reports of in gynecology practices where there's practitioners that are trained in lichen sclerosus detection. It can be upwards of 1 in 70. There's been reports in nursing home populations of 3.3% of people having lichen sclerosus. The bottom line is it's more common than we think, and it's often missed and it's often misdiagnosed. Next slide. Is lichen sclerosus an autoimmune condition? Well, the answer is that yes, it is an autoimmune condition. We haven't figured out all of the ins and outs of it, but this is from a paper that we published not too long ago, a few years ago. And then there's another paper that came after it, but it's looking at the pathway that we have identified that's happening within the cells in lichen sclerosus. And the way that this pathway was identified was from a study where we collected biopsies from lesional and non-lesional skin, meaning from lichen sclerosus area and then an area on the upper thigh of the same person that did not show lichen sclerosus. And we also collected biopsies from people in the same families. So mother-daughter pairs, sister pairs with lichen sclerosus. So we could determine genetics and we could determine the immunopathic pathway that was occurring. And actually, this research led to some targeted therapies that we are currently investigating and just finishing a study right now on JAKs inhibitors that target this pathway. So it was really valuable research and it's leading us in a good direction. The more that we understand about how lichen sclerosus works on the cellular level, the more we're going to be able to find treatments that are more targeted than topical corticosteroids and hopefully decrease any side effects while increasing how effective they are. So the future is really bright for upcoming therapies. Next slide. So what is my doctor looking for when they're looking for lichen sclerosus? So again, we're going to divide these into the lichen symptoms or those thickening symptoms and the sclerosis symptoms. So I'm using the medical terms first and then the description in the parentheses just to put this together. So your doctor is first looking for pigment changes, hypopigmentation, or that white appearance of the skin or lack of skin pigment. Now, I didn't put this, but I should also add that sometimes we actually look for darkening of the skin as well, because when lichen sclerosus is in remission and that inflammation decreases, especially on resorbed labia minora, sometimes we can actually see the body kind of put out a bit more pigment and the area can be a bit darker. We call that inflammatory hyperpigmentation, and it's nothing to be worried about. People always come and they think that it's skin cancer or something really worrisome, and it actually is not. It's a subtle sign that the lichen sclerosus is actually under control and the body is trying to overcompensate by throwing out more pigment. Lichenification is the thickening appearance of the skin, and it's a wax paper or crinkling appearance. And this is not easy to identify. When I identify it in the office, obviously I have a trained eye because I see hundreds and hundreds, if not thousands, of patients with lichen sclerosus over the years. But I'm also employing my microscope. It's called a vulvoscope, which has light and magnification to be able to see what I need to see as far as what's on the skin. And in addition, sometimes I employ a spray of dilute vinegar or acetic acid that helps to dehydrate the skin cells, and it's almost like a filter that allows me to see even better along with my microscope and light. And so people tell me all the time, well, how do I know if the patches are coming back, or how do I know if the thickening is coming back? And that's a hard one. That's why I do recommend that you see a specialist or someone familiar with lichen sclerosus either every 6 months, depending on who you're seeing, or maybe even once a year, just to make sure that there's no active lichen sclerosus or activity. Usually when there's thickening, there will also be itch. And so that's a symptom that can kind of go along with active lichen sclerosus as well. Fissures, those are the paper cuts or cracks that we were talking about earlier. And these are most commonly found between the labia minora and majora, so in that crease, as well as we tend to see fissures around the clitoral area. And then down at the bottom, that's the most common place we see fissures, is right at the vaginal opening at that 6 o'clock position. If you're looking at the vaginal opening like a clock, it's right in the center there. And that's unfortunately where a lot of people have scar tissue fusion and they tear over and over, especially with intercourse. So that's something that I'm always looking for. Another thing is purpura, which is that bruising or just the blood under the skin surface. And then, of course, we are always trying to rule out precancer or cancer. So vulvar intraepithelial neoplasia, or VIN, is that precancer and or vulvar cancer. And what I'm looking for as a physician looking for this, I'm looking for non-healing areas that are clumped up. And they bleed easily. And the key here is non-healing. So if something doesn't seem to be healing, it's always best to have that checked out and to ideally get a biopsy of that area to see what's going on. Now, as far as the scarring, what your doctor should be looking for are clitoral adhesions. Remember, adhesions are abnormal connections or scar tissue. Scar tissue sticking the clitoral hood to the glans clitoris. You can envision it like a hoodie over your head where the clitoral hood is the hoodie and your clitoris is your head. And so if there's glue stuck, then it's hard to pull that hoodie off your head. And so those are clitoral adhesions. And then if we pull the drawstring of the hoodie and it closes up over our head or our face, then that's clitoral phimosis. It's inability to pull back the clitoral hood from off the glans clitoris and expose the clitoris completely. Introital stenosis is narrowing of the vaginal opening due to scar tissue, and this often occurs at the top and the bottom of the vaginal opening. And we can have tearing at the top at 12 o'clock, as well as more commonly at the bottom at 6 o'clock. Also, vulvar granuloma fissuratum, which are tears or splitting in the areas of scar tissue. Next slide. How is lichen sclerosus diagnosed? Well, it's diagnosed clinically most often. However, it's ideal to have a biopsy as well to show the diagnosis. Now, if the lichen sclerosus is what we call in remission, or there's no active lichen sclerosus, and we're making the diagnosis based on scarring changes, history, and so forth in response to medications, then it doesn't make sense to do a biopsy because the biopsy is going to most likely be negative in the setting of remission and not active disease. However, if there is active disease, it is usually best to biopsy. Now, a caveat, I'm a specialist in lichen sclerosus, and so I will weigh the risk and benefit and talk to the patient about biopsy. I don't always biopsy because I am very confident in my diagnoses, but the reasons that I will always biopsy are, number one, if I'm unsure about the diagnosis, or if I think it looks like lichen sclerosus, but there's something else I believe going on as well, whether that be a fungal infection, a bacterial infection, lichen simplex chronicus, which is an itch scratch itch cycle, or lichen planus in addition to lichen sclerosus. So if I'm unsure of the diagnosis or I don't think we have the full picture, then I will recommend a biopsy. I will also always biopsy if I'm concerned about VIN, which is precancer, or a squamous cell carcinoma. If I'm ever concerned about cancer, I will always recommend strongly a biopsy. And then, of course, biopsies are important to definitively diagnose lichen sclerosus, especially if you really need a biopsy to get medical care, which I've had patients, such as my Canadian patients, who really need that to get quicker care and so forth. But the answer is you can diagnose lichen sclerosus clinically. You do not always have to biopsy, but a biopsy is a plus. Next slide. All right, what are we looking for in a vulvar skin biopsy? So I think that it's really important to understand what we're seeing because it tells us what's going on within the layers of the skin, and it just makes it more understandable for what you're feeling, right? So I know I'm bringing in some histopathology here, but I'm going to really break this down. So if you look at this slide here, this is basically a section of the biopsy. So you can think of the biopsy like a block, right? Like a wooden block of tissue. The top of the biopsy is going to be the skin that we feel on the outside. And then the bottom of the biopsy is going to be the bottom of the skin that attaches to our body, right? The basement membrane that attaches to our fat layer that attaches to our body. And so going from the top to the bottom, the outside to the inside, or from shallow to deep, right? We see marked A, that kind of reddish pink area is that top layer. It's called hyperkeratosis. So keratin is what makes up our nails, right? So and it makes up our parts, our skin as well. But it's hyperkeratosis. So it's more thick, like almost like a stiff layer, right, on the very, very top. And not only that, it's not only stiff, but it's actually a bit thin compared to healthy tissue. B is the top layer, and it's thinned out and it lacks the ridges that hold it to the layers below. So typically that purple area going into the lighter pink area under it would have something called reedy ridges, which are basically like lock and key, kind of like the top of a castle. And that is like a zipper, right? And it holds that layer of skin onto the layer underneath. So it holds that purple layer onto that pink layer. And the issue is that in lichen sclerosus, that instead of being like the top of a castle, it's more flat. And so this can lead to lead to the bruising that we talked about. It can lead to disruption of the skin being much more fragile, and the skin tearing more easily. And then underneath in layer C, you can see that collagen is very uniform, and this is homogeneous collagen, and that's below the dermal epidermal junction, which is kind of the layers that we're in. So when I talk about inflammation causing changes to the cell layers regenerating, this is what I'm talking about. They incorporate stiffer forms of collagen in a more haphazard pattern, and that's what makes up the middle part of the skin layer. So that is the thick area. So when we say that lichen sclerosus is thick, this is what we're talking about. That middle layer is thick, and then the caveat is the very top layer is actually thin. But the entire skin is not thinned out. It's just these changes that we see. And then the most important is down at D. You can see all those little purple dots. So those are inflammatory cells. They're called white blood cells, and it's called a lichenoid T cell infiltrate. Infiltrate means they're all gathering down at the bottom. So that's that inflammation gathering at the bottom, right over the basement membrane, changing the way that the cells above regenerate. And we can actually see all of that in this teeny tiny little skin biopsy that's probably about 3 millimeters, which is absolutely incredible. So next slide. Can lichen sclerosus lead to vulvar cancer? The answer, unfortunately, is yes, but it's uncommon. So there's a 4 to 6% risk of developing vulvar cancer, and the type of cancer is a squamous cell carcinoma. But this is typically when there's inflammation that is left unchecked, meaning if there's lichen sclerosus that is active for a very long time, and what we do see is that first it becomes a differentiated vulvar intraepithelial neoplasia, which is basically a precancer, and then that leads to squamous cell carcinoma. The idea behind this is if there's a layer of inflammation that's changing the way that the cells regenerate, just like we talked about, then that inflammation is a setting in which the cells can make more mistakes. It has to do with oxidation. And so if the cells are making mistakes, that is what's turning into a precancer or a cancer. Now, what we know is that when we decrease the inflammation in the bottom layer of the skin, we also decrease risk of vulvar cancer. It also allows the skin cells to regenerate in a more healthy way. And then it can take away the symptoms of the lichenoid symptoms, so those itch type symptoms that we talked about earlier in the talk. And this is supported by research. Basically, there's been studies, including a relatively long-term study that lasted 7 years, and then a meta-analysis, which is where we take all the data from different studies and we put it all together and we do statistics on that, so it's more powerful. And that meta-analysis that was published recently last year by one of my colleagues in Brazil showed that there is a decreased risk of vulvar cancer in lichen sclerosus with the use of topical corticosteroids. Next slide. So that brings us to how is lichen sclerosus treated. You may recognize this slide as one of the posts that I share on Instagram. And basically it divides our treatment options into medical options and energy-based modalities. So, and I actually have to update this because there's some new things coming down the pipeline as well that are very exciting. So our medical options include ultra-potent topical corticosteroids, which are currently the first-line treatment. And the reason that they're first-line treatment is because we have the most evidence behind them as far as the research goes. So when we're looking at quality research, we're looking at randomized control trials. So, really evidence-based, and there's a lot of evidence showing that that topical steroids are effective in decreasing the inflammation, both on biopsy specimens before and after, compared to many other different treatment modalities. There's just been a ton of research behind it. So we don't say that lightly. That is based on a lot of evidence. Our second line is topical calcineurin inhibitors. These are medications that are more targeted. They're immunomodulators. So they affect that immune system pathway that I showed you earlier in the talk. And they decrease inflammation by affecting parts of that pathway. And they're a bit more targeted than topical steroids, which are a bit more broad in their action. And so topical calcineurin inhibitors include things like tacrolimus and pimecrolimus. You may have heard the brand Protopic. So that's what those include. And then along with those, but a different class, are JAK inhibitors. And those are new, relatively new. There's a number of them that have been developed, and they treat anything from atopic dermatitis to eczema to vitiligo. And so these are very promising. They're even more targeted. And so we just completed a study on a JAK inhibitor called ruxolitinib, and lichen sclerosus. And previously there was a study on this JAK inhibitor with lichen planus, and it showed promise in both. And so I'm really excited. We just finished the safety visits for that. I saw many of those patients up at the DC office, and then hopefully we'll be analyzing the results soon and hopefully getting something out, and hopefully, in the next 2 years or so, it will get an FDA indication is my hope. And this goes by the brand name Opzelura, if anyone has heard of that. In addition, as far as treatment options, there's also platelet-rich plasma injections, or PRP. Some people have heard of this. Unfortunately, the data is not great for PRP. It has not been shown to decrease inflammation in biopsy specimens collected after the treatment versus the ones before. And then we have our energy-based modalities. And these are interesting. They can work in different ways. There's photodynamic therapy that has some evidence behind it, but again, it's still experimental. There's high intensity focused ultrasound, which has a lot of great, really promising evidence behind it, but unfortunately it's not available in the United States. We did try to get a hold of that. Most of the studies have been done in China, and unfortunately they would not send us a machine so we could study it. But hopefully in the future we'll develop a technology and we can kind of figure that one out. And then there's the fractional CO2 laser therapy. These are things like the Mona Lisa laser. There's been a number of studies on this. However, out of the 2 big randomized control trials that were published in the Green Journal recently, one of them being one of the studies I was involved in, that study included biopsy before and after laser treatment, and there was not a decrease in inflammation in the blinded biopsy specimens after treatment compared to before. So we can't say that laser at this point reduces cancer risk. It's really only been shown to improve symptoms. And there may be different mechanisms by which that happens that have more to do with atrophy or genitourinary syndrome of menopause rather than lichen sclerosus. So the jury's still out on that. It's an experimental treatment. The next stage of this is they're trying laser therapy with topical steroid to see if that is more effective. It's especially in people that don't respond to topical steroid alone. So more to come. There's been a few pilot trials on that, but we'll see if that works a little bit better. Next slide. Are there any non-steroid treatments for LS? Well, again, I pretty much went over all of this, but ultra-potent topical steroids are the gold standard at this time, and they're the only well-studied treatment to decrease vulvar cancer. But alternate and experimental treatments include topical calcineurin inhibitors, Janus kinase or JAK inhibitors, and energy-based therapies that we just reviewed. Next slide. All right, how can I holistically improve my LS symptoms and flares? So it's great that we have all of these medical options, but really, what's going on with lichen sclerosus is it's a reaction or an overreaction of the local immune system in the skin where the protein or proteins that have to do with lichen sclerosus are expressed. And so just like the immune system of the whole body, the immune system of the skin relies on a few things to stay healthy. And so promoting local immune function is really important in autoimmune conditions such as lichen sclerosus. And so how can we do that? Well, we can do that by what we're putting in our body because a healthy diet provides nutrients and then those nutrients go to the cells of our body and gives our cells what we need to help them regenerate. We also know that there's a role of stress and stress management because when cortisol levels are high, we can see changes in the immune system and how it functions, right? We know that works with our whole body. It also works locally. And so stress management can play a role as well. Limiting irritant and allergen exposures. So there, oftentimes with lichen sclerosus, there is a bit of a deficit in the skin barrier. It's not as healthy as someone who didn't have that inflammation or didn't have lichen sclerosus. Sometimes in lichen sclerosus, there's other factors that affect our skin barrier, whether they be hormonal, or other factors related to muscle, where blood flow is not optimal getting to the skin. And so it is really important to make sure that we're using products that are not going to irritate already irritated skin or skin that has a tendency to get irritated to allow it to heal. And then, of course, protecting the skin barrier. And this includes optimizing from a hormonal standpoint, whether that be applying a hormone if our ovaries aren't quite working very well anymore, whether that be in perimenopause or menopause, or optimizing if we are supposed to be ovulating and we're not, to try to figure out why that is not happening, as well as locking in moisture using an emollient or a moisturizer on this area to lock in moisture and to protect the skin barrier that way. Next slide. Lichen sclerosus can be in remission and still be symptomatic. Let's take a moment and just go over what that means. So the first thing we need to go over is what is remission? So we talked earlier about active and remission. Let me make sure that that's that makes sense, right? Because it's important. So basically, I can't see how much inflammation is at the bottom of the skin. I don't have X-ray vision. I wish I did. It would make my job so much easier. But what I can tell is I can look at the surface of the skin, and if the surface of the skin has that wax paper crinkly appearance, then that indicates thickening. and that indicates that there's a high level of inflammation under the surface. The way that I explain it to patients is, say I have a tub of river water, like mucky water where you can't see the bottom, and I'm swirling my hand around. That's supposed to be the inflammation. I can't see my hand through the water, but I can see the ripples or the waves on the surface, right? So I know that there's a lot of activity going on under the surface. However, if I kept my hand still and there's no inflammation, then the surface would be calm. And so that is what I'm looking for. When the surface is calm, we call that remission. Usually, when people are in remission, it means that the inflammation level is low, and that means that they're not having the lichen symptoms, meaning the itching, namely, but also meaning the cracking, not tearing. So, tearing they can get from scar, but it's more like that crack, that cracking. And then let's see, itching. The pigment may not change, so they still may have whitening, but we're really looking for those thickening symptoms. The bruising usually goes away when someone's in remission as well. However, people can still have symptoms, because remember, it's only half of the equation. We have the lichen or thickening symptoms, and then we have the sclerosis symptoms. And we're going to be spending a bit more time on some of the sclerosis or scar tissue symptoms, because just decreasing the inflammation under the surface does not usually reverse scar tissue that has already occurred. So when we're talking about coverage of the clitoris, when we're talking about scar tissue at the top and the bottom of the vaginal opening, resorption of the labia, those anatomy changes that have to do with scarring, those are not typically going to be reversed with a treatment that's going to decrease inflammation, such as a topical steroid immunomodulator, what have you. And so we need to talk about other options for scarring. Usually symptoms with scarring are going to be your tearing at that 6 o'clock position or the 12 o'clock position, tearing around the clitoris, your decreased clitoral sensation, pain at the clitoris, pain with vaginal insertion. And a lot of that falls into the realm of sexual effects, right? Next slide. How does lichen sclerosus affect sexual function? So this is a perfect bridging point. So women with lichen sclerosus are less likely to have vaginal intercourse, oral sex, or masturbate than control groups. This is based on research. So this is what the research tells us. Dyspareunia, which is pain with sex, is frequently the initial presenting complaint of women with lichen sclerosus. That's what literature says, and that's interesting. It's frequently the initial presenting complaint, but I would say itch is probably what brings people to the doctor the most. Despite adequate medical treatment, women with lichen sclerosus continue to have significant sexual dysfunction, as assessed by the female sexual distress scale. Okay, so this is interesting. So and this goes along with what we were talking about. So even when we treat with clobetasol, people are still having sexual dysfunction, and they're most likely having sexual dysfunction relating to the scarring, but it could also be related to other factors. For example, if the hormone component is not addressed, right? And they still have vaginal dryness, or they have pain with sex due to the glands not producing adequate lubrication or being irritated, or there can be medical trauma involved. There can be relationship trauma. There can be so many factors. We're more than just the vulva, right? We're a whole body. And so lichen sclerosus affects people very deeply. And this all needs to be uncovered. You can't just fix that with a tube of steroid. And then clitoral phimosis, or coverage of the clitoris, can also cause anorgasmia. We also know that from the research. So we can see in practice, I see people with decreased orgasm, blunted orgasm. It takes longer to orgasm, and they've noticed a change. If that change bothers them, then we definitely need to talk about addressing that and what the options are for addressing that. Next slide. So this is a study that I conducted with a number of colleagues, and we were looking at sexual symptoms in women of reproductive age with lichen sclerosus. That's what this figure is from. However, we also looked in the literature of all ages, and then we conducted another study with all ages, and it was similar. So here we go. We have decreased clitoral sensation. And the important thing to look at with these symptoms is we divided it, because symptoms can, you can look at it in different ways. That mauve bar is symptoms experienced. So what did you experience? The darker one, the kind of terracotta color, are symptoms presenting or prompting medical evaluation. So what did you tell your doctor? What brought you to the doctor? What was the tipping point where you're like, I need help here? And then that beige or tan is symptoms that affected the individual the most. And it sounds like similar questions, but it really actually is very different. And so what we found is that many people experience decreased clitoral sensation, but hardly anyone told their doctor about it. You can think about the reasons why, right? And then you can see that dyspareunia, a lot of people experience pain with intercourse. A lot of people experience tearing with intercourse, but it was less so what they brought to their doctor, but still actually pretty high. It's encouraging. And then obviously itch, they brought that to the doctor, even though it wasn't the thing that may have affected them the most, or not everybody experienced it, which is important to know too. I've met a lot of patients, especially in their reproductive years or 20s, 30s, 40s, who said, yeah, it was really just tearing and pain. I really never had itch, right? Although a lot of people do have itch. So, and then also soreness and pain and tenderness seems to be rated a bit lower. Next slide. What are the treatment options for clitoral pain due to scarred coverage of the clitoris or clitoral phimosis? So now we're going to get into treatment options for each section when we're looking at scarring. So the first step, we can clean the area, right, with water, gently pulling back the clitoral hood and ensuring there's no buildup around the clitoris. Because what tends to happen is we're constantly shedding dead skin cells from our body, and those dead skin cells can combine with sweat in the area, moisture in the area from discharge, or whatever it might be, and then they can get trapped in under the clitoral hood. And if there's stickiness of the clitoral hood to the clitoris, they can get trapped behind there. And then what can happen is they can actually ball up with friction and form what's called keratin pearls. This is basically, keratin is that top layer of skin that gets shed naturally, and then when it balls up, it creates a pearl. So it's a hard, balled up skin cell area of ball of skin cells that can get trapped between the clitoral hood and the glans clitoris, and it can obviously, as you can imagine, cause discomfort, especially when it gets trapped in there, because these are round little nodules. It's almost like having a grain of sand trapped in your eyeball, right? It's irritating and uncomfortable. Little bits of hair can also get trapped down in that area as well, and I've seen that cause clitoral pain and discomfort. If coverage of the clitoris is moderate to severe, then a specialist may need to perform a minor procedure with local numbing medication to separate the scar tissue around the clitoris, remove buildup and or keratin pearls from the area. If the clitoral coverage or phimosis is mild, sometimes we can get away with just doing this, in the office, or you can clean it at home yourself. All right, next slide. What are the treatment options for decreased clitoral sensation due to coverage of the clitoris? So I should preface this by saying that most people with clitoral phimosis have intact clitoral sensation and do not have decreased function. So that's really good news. So most people actually are able to orgasm. Their orgasm may be blunted, but it's been covered so long that they don't really know the difference, and we wouldn't know unless we uncovered it. I would say if people are able to orgasm, it's not bothering them, they're not having clitoral pain, then really we don't really need to do anything about it if it's not bothering the person, and they're having function, right? But there are people that have decreased function, decreased clitoral sensation. So the first line approach is going to be increased pressure on the clitoris, whether that be with a vibrator or using more pressure with manual stimulation, adding vibration to promote blood flow and to increase the intensity, and then scar tissue massage to gently break up scar tissue between the clitoral hood and the glans clitoris. If the adhesions are mild, then it can often be done. And then if they're moderate to severe, that's when we may need a specialist to perform that minor procedure with the local numbing medication and or under sedation to uncover the clitoris. We call this a clitoral dorsal slit procedure with lysis of clitoral adhesions. That's the technical term for it. But essentially, once you're completely numbed up or you're asleep, we are very careful in separating the clitoris from the clitoral hood. And then once we have good separation of those to ensure safety, we basically just uncover the clitoris. And you want to go to someone with a lot of experience, obviously, in doing this procedure, because that's important. All right, next slide. What are the treatment options for tearing at the vaginal opening with intercourse? So the first step approaches are going to be optimize the health of the tissue. If the tissue is healthier, then it's less likely to tear. That being said, sometimes there has been so much scarring, tearing, readhesion over and over, that there's just so much scar tissue that if there's a scar tissue bridge or that kind of band, we do need to do a minor procedure to remove that scar tissue. But starting with first step approaches, we want to decrease inflammation in the tissue that's tearing. And with lichen sclerosus, that means decreasing inflammation with either a topical corticosteroid or a immunomodulator or what have you, to allow those skin cells to regenerate in a healthy manner. We also want to increase hydration to the skin with a moisturizer or an emollient after a soak or shower to lock in that moisture and to help that tissue become healthier. We may want to add a topical estrogen or even an estrogen testosterone compounded cream or gel if there's a reason for lack of hormone, like perimenopause, menopause, or anovulation, really to help that skin become healthier. And then if there's underlying tight, superficial perineal or pelvic floor muscles, we want to address that as well, because that's impeding blood flow, not only to the muscles, but the overlying tissue. And so that tissue is not getting the oxygen, nutrients, and the hormone that it needs. And so optimizing the tissue health by looking what's under the surface and making sure that the muscles are released. And that's through pelvic floor physical therapy, including myofascial release and perineal massage, to help stretch the scar tissue as well as bring health and blood flow to the tissue. Next slide. When should I see a pelvic floor physical therapist? Pelvic floor physical therapy is really helpful when there are bowel issues, bladder issues, pain with intercourse, muscle tightness, especially in the pelvic floor, but in other areas of the body might be a clue. So if someone is clenching their jaw or they have tension headaches, there's tension in their neck, they hold their glutes tight, they have back pain, they may have abdominal tightness. These are all clues that the pelvic floor is likely tight as well. And so there's utility in seeing a pelvic floor physical therapist. They also can help with application of medications and scar tissue release techniques, including that myofascial release, the perineal massage that we were talking about. And of course, you should see a pelvic floor physical therapist if your doctor or healthcare professional recommends it. But again, that recommendation is going to be based on the things that we talked about. All right, next slide. When should I see a lichen sclerosus specialist? So you can see a lichen sclerosus specialist at any time if you're concerned about lichen sclerosus, or if you have been diagnosed with lichen sclerosus, or if you feel that you have it and everyone's discounting, right? But also you can see a lichen sclerosus specialist if you do not feel well equipped to manage lichen sclerosus and you feel like you need to know what's going on in your individual situation, the why behind it, how to optimize your skin and your tissue. If you need a more personalized approach, right? If you really want to know how to treat it and you feel like you're not getting answers, if first line treatments are not working, right? or if you're interested in surgical options for scarring, I would recommend seeing a specialist for those reasons. How do I find clinicians familiar with lichen sclerosus? Well, a really good resource is the Lichen Sclerosus Support Network. They have a fabulous directory of people who want to see people with lichen sclerosus, and people who specialize in lichen sclerosus and other skin conditions. So I definitely recommend checking that out. You can also get recommendations for specialists with lichen sclerosus through physical therapists. They're often in the know, through your gynecologist or your primary care doctor. And these are all helpful resources. Next slide. And how can I get help with lichen sclerosus research to increase awareness and treatment for the future? So some things that we can do are participating and conducting research studies, donating to promote research, and sharing evidence-based information as you feel comfortable within whatever network you have. And it's really important to promote the research in this, because that's how we're going to find better treatment options than what we have now. And I think we are going to need, definitely need funding to get the bench research done, as well as get these treatment options and to make them available. And then it's also really important to translate the research, right? And that's what I try to do in my Instagram, because a lot of these journal articles are behind paywalls, even for me. And so you have to have a society membership, or you have to have a institutional affiliation to even access them. And then you have to think, well, who's reading these, right? And so I like to basically break down the research and then share it in a way that we can all understand, because that's going to be the important part. Next slide. And then how can I find support for lichen sclerosus? So we're showing support for lichen sclerosus by honoring World Lichen Sclerosus Awareness Day today. We have more people who have tuned into this presentation than any year before. I have been giving presentations on Lichen Sclerosus Awareness Day for, I believe, the last 3 years, maybe 4. And so ever since we started really bringing awareness to it, and every year it grows and grows and grows. And so I've been with Kathy and Jackie since the beginning of this, when we were all new babies learning how to do Instagram. So it's been quite a journey, but I'm really proud of Lichen Sclerosus Support Network and the work that everybody has done. It's absolutely incredible. And so I feel very honored to even be speaking with everyone tonight. Next slide. All right. And with that, if you would like more information on the conditions that I see and treat, including lichen sclerosus, but also including chronic vulvar pain of other causes, as well as recurrent vaginitis and menopause, you can follow me on social media at JillCraftMD if you don't already. And then my new office, which I'm really excited about. So for any of you who have been kind of following along with my journey, I did move down to Tampa, Florida from Washington, D.C., moved the entire family down, and I started my own practice. And so I am in South Tampa, in Tampa, Florida, 10 minutes from the airport. And if you'd like to come visit me, I'd love to see you and make you my patient. So with that, I will answer any questions that anyone has. All right. So the first question is, does hypopigmentation always mean active LS, or is it also present in remission? Great question. So the answer is that it does not mean active LS. It's actually present in remission. So right now, with what we have, topical steroids can normalize or make healthy the skin texture, but they can't always, and usually don't, reverse pigment changes. So that lightening, that hypopigmentation typically will remain. Now, what's really interesting is the JAKs inhibitors, like Rux that I was talking about. It's actually approved for vitiligo. And so when we were doing the trial, what I was noticing is that pigment was returning in lichen sclerosus patients. And so that is just incredible. And so I think that we have some exciting things to come as far as restoring pigment. But that's a great question. So I have a ton of patients, almost everyone, that has whitening, whether that be obvious or subtle, and they are in remission. We're really looking at skin texture to determine if there's activity. Next question. What symptoms should we be worried about with anal LS? Yes. So the important thing is we always say vulvar LS, but lichen sclerosus, it occurs in a figure of eight position often. So the vulva as well as the perianal area. Now, that being said, I have a lot of patients that just have the vulva affected. And I even have a number of patients who just have the perianal area affected and nothing on the vulva. That's less common, but I do see it. And so as far as what we should be worried about, it's the same as what we think about with the vulva. So we want to make sure that lichen sclerosus around the anus is in remission. We want to make sure that the area is healing and regenerating in a healthy way, that there's no clumped up or easily bleeding areas or areas that we're concerned about that would be a precancer or a cancer or require a biopsy. Obviously, we want to take care of fissures in that area because there's a bowel movement addition in that area. And we can get away with not having intercourse, but we can't get away with not having bowel movements. We want to make sure that bowel movements are soft, so increasing fiber, making sure that we're not constipated, enough hydration in the diet. If there's a pelvic floor component that's causing an outlet obstruction, we want to work with that with the physical therapist to release the pelvic floor and to help prevent fissures and hemorrhoids and all of those things in the perianal area. Can the steroids be dangerous for my partner? Interesting. Okay, so the idea here is that when we're applying a steroid, we want to, number one, apply it in the most effective way. And what that means is that if there is thickening of the skin, we want to soak prior so it softens the skin. Because remember, in that biopsy that I showed you, the inflammation is all the way at the bottom, right above the basement membrane. So we want to make sure that that the skin is prepped in order to receive the steroid. And then when we put the steroid on, we want to use a very small amount, a pea-sized amount, and rub that in completely so it absorbs into the skin. It should not be a layer just glazing on top, because then that is going to thin out that already thinned out layer on the very top. And it's also going to be a risk factor for if someone has herpes, genital herpes, they're more prone to outbreaks if that top layer is kind of more the immune system isn't working so well at that top layer with the steroid. And then they're also at risk for yeast and bacterial superinfection or skin infection, almost like a baby diaper rash on that area. So we want to make sure we're completely rubbing that in. So if it's completely rubbed in, there should not be transfer to a partner. I probably wouldn't recommend having sex right after you apply the topical steroid, but theoretically, if it's completely rubbed in the right way, it really shouldn't matter. The amount that we get on a partner is minimal and infrequent relatively. So no, I don't think that there's any safety concerns with being intimate, along with applying a topical steroid, especially if it's rubbed in appropriately and you're not having activity directly after. If there is pain with vaginal insertion, is it good to have sex to juice things up and get the blood moving, or will sex make it worse? I get this question all the time, and it really depends, right? So we're weighing things out. So if there's pain with insertion, then you can think of sex as dilator therapy, but you could also think of sex as something that's kind of reinstating the pain cycle. So it depends on how you're utilizing the sex. I would say if you have a treatment plan and you're working on things and you know what's going on and you know the things that are involved in this, and you're able to employ techniques, whether that be deep breathing or stretching or you're working on applying hormone to the area, or you're working on, a scar tissue band or what have you, I think that you can have sex with realistic expectations, knowing that, if it hurts, you either want to change position, or you want to use more lubricant, or you want to stop, and be intimate in another way to kind of keep things going, or have an orgasm in different ways. I'll let you use your imagination there. But if you're finding that you're just like bearing through it, it's an awful experience. It's like you're just like it's traumatic. Like that is not what we're going after. So it really depends on how you're going into it. I wouldn't just bear with it for like the common good, or like thinking, okay, it's increasing blood flow, because there's other things that we can do to increase blood flow that are definitely not as painful. Next.
So I just got word from Kathy that was our last question. We're going to respect everyone's time. We're almost right up at the hour. So I want to thank you, Dr. Krapp, on behalf of the Lichen Sclerosis Support Network, and I'm sure on behalf of all of our attendees as well. It was wonderful listening to you speak, as always. And just a couple quick notes for our attendees. Thank you so much for those who have already donated. This is a great reminder of how much work there is to be done in the field. And if you found this session helpful, please do consider donating to LSSN. If you didn't get all of your questions answered and you have not familiarized yourself with the LSSN website, you should take a look at that. It is at ls and then supportnetwork.org. So lssupportnetwork.org. And we shared at the beginning, again, all of Dr. Krapp's ways to get in contact with her website, and her social media. So that is the way we're going to close out this evening. I hope everyone enjoys the rest of their Wednesday, and thank you for joining us to support LS Awareness Day.